Welcome everybody who's here. This is our virtual follow-up for the ILD Community Network, linking APPs with ILD experts. My name is Robert Laugherty. I'm a rheumatology physician assistant in Alcoa, Tennessee. And with me tonight is Erica Ludtke. She is a pulmonology nurse practitioner that works at Vanderbilt in Nashville, Tennessee. So welcome to everybody. And we want to thank our sponsors. Boehringer Ingelheim is our founding sponsor, and then we also have a platinum sponsor in United Therapeutics, and we sure appreciate their support for this program. So let's get into this. We want to talk about uncovering the clues, and this is all about looking at cases tonight. We covered one case last week at our live presentation, and this is going to be an entirely case-based journey through interstitial lung disease in rheumatic disease. So case number one, and this is something that we see a lot, and patients always, this is a phrase that they use. I thought RA was all about joints. And we have to inform them that no, it's a systemic disease and it affects more than just their joints, potentially. And we want to learn to recognize and manage rheumatoid-associated interstitial lung disease. So our first case, the snapshot, his name is LBJ, which I thought was interesting when we think of presidents.
I thought the same thing.
Thought that was kind of cool. He's a 67-year-old male. His presenting complaint is increasing fatigue and shortness of breath with mild exertion over the last 6 months. And he has a background of rheumatoid arthritis. He was diagnosed about 4 years ago. He had a positive rheumatoid factor as well as a positive anti-CCP. And both of those were in the relatively high range as well. He was started on methotrexate, and adalimumab was added about 2 years ago to maintain his response rate and help him improve his rheumatoid arthritis. So, what features do you think in his history suggest a higher risk for interstitial lung disease? And as we know from our program last week, any rheumatoid patient who has high titer rheumatoid factors and high titer anti-CCPs are going to be at a little bit higher risk for developing interstitial lung disease down the road. So his exam, he does have those inspiratory crackles when we're listening to him, that Velcro sounding at the base of the lungs. But he has a normal oxygen saturation at rest. But if he starts walking, he'll desat. And if we look at his chest x-ray, he does have some interstitial markings. The initial tests that were ordered were the pulmonary function test, which showed a forced vital capacity of 65% of normal and a DLCO of 41% of normal. And as per protocol, we wanted to get a high resolution CT of his chest, which showed basal predominant reticulations with honeycombing, very consistent with a UIP or usual interstitial pneumonitis pattern. So we need to take a step back and look at, well, what do the ACR and chest guidelines from 2023 recommend for a patient like this who has suspected rheumatoid arthritis associated ILD? And, he's been on methotrexate. And while that can be associated with some hypersensitivity pneumonitis, that's something that usually happens early in therapy, but there's no consistent improvement or even any guidelines with respect to continuing methotrexate. So we usually take them off of that and get them on that backbone, as you called it, Erica, of mycophenolate. But also recommended would be azathioprine. Rituximab could also be a choice. Cytoxan could be a choice, along with glucocorticoids short term would be some of the choices that you would have to look at. And from here, this is a patient that I would probably switch to mycophenolate, but at that instant, I would also call Erica and say, hey, this is somebody that you need to see. And so she's going to tell you what she does next.
Okay, so they come my way, and indeed they do have a UIP pattern ILD. As Robert mentioned, we know that methotrexate has some associated pulmonary toxicity, but it really is more of an inflammatory pattern, tends to happen earlier in the course with methotrexate, and is really not UIP pattern. So whenever I see UIP pattern ILD in an RA patient, that is almost always associated with their rheumatoid arthritis. Again, he's been on methotrexate for 4 years. The adalimumab was started 2 years ago. And to take him off the methotrexate is pretty much standard of care. Even if we don't think, yeah, the methotrexate probably didn't cause this, we still take him off. So risk factors, why he is high risk. If we think about it, he knocks off all the boxes, right? He's an older male. He does have a high titer RF, and he also has a positive CCP. And that combination makes him really high risk for developing RA ILD. If you threw smoking in there, then you'd be knocking it out of the park. So if we think about what baseline and follow-up assessments that we need, obviously the HRCT is kind of our first step. And then we need pulmonary function tests, which he has, and then to continue to follow pulmonary function tests. In general, we follow about every 3 to 4 months initially. Some folks end up spreading it out to 6 months, but for anybody with UIP pattern, we tend to stick with the 3 to 4 month mark. And then HRCTs annually to, every other year is about where we stick. If they have a smoking history, then certainly, usually you're going to do annual CTs just to also cover that lung cancer screening.
Erica, if you have a sudden change in their pulmonary function test, would that prompt you to get an HRCT maybe a little bit sooner?
Yeah, anytime I have a big drop off in pulmonary function tests, especially if it's a symmetric decline in their FVC and their DLCO, then that's going to automatically reflex for me to get an HRCT sooner. If they have a disparate decline in their DLCO with stable spirometry, then I usually go, okay, let's probably get an echo first and see if there's any, new onset heart failure contributing to it. Make sure we have, an up-to-date CBC and ensure it's not anemia contributing. But if it's an across-the-board decline, their FVC and their DLCO is down, then I will just do that HRCT earlier. Okay, so evidence-based management. We talked a lot about kind of the switching of the therapies from a rheumatology perspective, which Robert did a great job at. Again, it's getting off the methotrexate. Again, not because we think that the methotrexate caused this. I'm very clear with patients on that. But what we know is that there are better agents for folks who have RA with ILD. So that's why we do it. Other things to think about is this guy has a UIP pattern CT, and we know that people who have UIP pattern CTs, even if it's not IPF, in larger data, they tend to follow a similar trajectory to folks who have IPF. They just don't do as well. So I'm quick to start these folks on antifibrotics. In this case, this patient was started on nintedanib. And then, plus or minus adding that nerandomilast in the future. And then for this guy, he was started on low-dose pred just for short-term control. If we think about other things to optimize him, obviously we have him on immunosuppression, and he now has ILD, so he's at pretty high risk for some sort of complication from an infection. So getting him his pneumonia, his COVID, his flu, all of those vaccines is great. Tdap, I always look for that one, especially if folks have grandkids and are around grandkids who could be curing whooping cough. So I always look for that one. And as I said, PFT is about every 3 to 6 months, and then a repeat HRCT at 12 months.
Sounds good. Abatacept in a patient like this is a good choice, if only because the infection risk seems to be less
Yeah.
with the Rencia. So,
People tend to like it for their joints for the most part.
oh, yeah, no, it's a very effective drug.
Yeah.
A patient, even in the absence of ILD, who has recurrent infections on other medications like a TNF inhibitor, I will invariably choose Abatacept for those folks. It works really well.
Okay, so kind of to summarize, we talked about this a little bit. High risk RA patients, which are those older men more than women, people who have a high titer RF, a positive CCP, those who are smokers, really do need ILD screening. The latest guidelines recommend an HRCT, certainly if somebody is really high risk. I think monitoring PFTs is also something that's reasonable. Robert, how do you practice with that in your environment?
I'm going to start with the chest X-ray, of course, and if there's anything on that, we'll immediately do the high res CT and go ahead and get them scheduled for PFTs, maybe without a consult at first, just to gather the data. And then if it comes back suspicious, then we'll definitely call pulmonology to get them hooked up with you guys. Uh, so
Wonderful. Um, Good. I will let you take over on this one.
so we have a systemic sclerosis patient. Comes in talking about it's getting harder to breathe. Her name is DA. She's a 56-year-old Caucasian woman. She's had worsening dyspnea over the last 6 months and a dry cough. She has a known diagnosis of diffuse cutaneous systemic sclerosis, and she was diagnosed within about 2 years ago, and that's going to be important. So, the clinical features of her systemic sclerosis are very typical. She has skin thickening on the extremities up to even proximal of the elbows. She has Raynaud's as well. And she also has GERD. So, she's got some esophageal dysmotility issues likely. Um, Her antibody profile does show a positive anti-SCL70. So, let's think about, what are her risks of developing ILD? Well, one of the biggest things is that it's early in her systemic sclerosis diagnosis period, and you're much more likely to diagnose ILD in a systemic sclerosis patient within the first 2 years of their systemic sclerosis diagnosis. Um, and then what baseline screening would you pursue? And of course, we're going to sound like broken records for the rest of the night. Uh, Chest X-ray, resolution CT of the chest, pulmonary function testing, echocardiogram for sure in a patient like this with systemic sclerosis. And I would, just good baseline labs, CBC, CMP, SEDRA, CRP. I would probably um, recheck a few antibody levels as well. Maybe recheck an ANA level. Check muscle enzymes at times in these patients as well. Go ahead and check an aldolase and a CPK. So, worsening dyspnea over the last 6 months. She desaturates on exertion. Pulmonary function tests, the FVC is 71%, the DLCO is 52%. Both of those are low, of course. And it's downtrending from her baseline, so it's getting worse. The HRCT shows this early honeycombing again with the UIP pattern. So we'll hear from Eric on what are the next steps in managing a patient like this, and would you initiate treatment or possibly even consider a referral to the transplant service for these folks? So, what do you think, Erica?
So, for next steps in management, certainly we have an HRCT, we have our pulmonary function tests. And if we go to the next slide here for me, there we go. Treatment, again, Robert and I have talked about that mycophenolate backbone is really important. And I will say, and I don't know, Robert, if this is your same experience, but A lot of the folks with systemic sclerosis tend to have a harder time with mycophenolate and are more likely to tolerate myfortic. Do you find that?
I have seen that in the past. I probably haven't treated enough of these patients to have an adequate, group to cull from, but I do know that that can be the case.
Yeah. I would say about 50-50. I end up having to switch patients over to, kind of the coded version that's a little easier on the GI tract. So that started. In this case, we think about, again, UIP pattern, right? So do you go towards something like an antifibrotic, such as nintedanib or Jascade or nerandomilast, I should say, and I would not start both of these at once. I will tell you that when I've done that, it's a very high rate of failure because, systemic sclerosis tends to affect the GI tract. And they have a lot of dysphagia. They have patulous esophagus with GERD, right? And so if you start them on multiple agents that potentially have GI side effects, things go it left really, really quickly. So I pick usually the most important thing first, which is controlling their underlying disease. And that's the mycophenolate or, myfortic. Then, if that goes okay, so let's say great, they tolerate the mycophenolate. Then I talk about down the line adding either nintedanib or nerandomilast. And again, discussing the risks and benefits with them. In general, I think nerandomilast is a little bit better tolerated from a GI standpoint. That's what the data tells us. So I've been reaching for that more with these systemic sclerosis patients than I would the nintedanib. I will tell you with nintedanib, even at a reduced dose, it is a really hard drug for these folks who already have GI problems. So I don't think the success rate with that is as good. Again, limited data thus far on nerandomilast, just because for progressive pulmonary fibrosis, we've really only had it out about a month. But thus far, seeing a little bit better tolerance with that. Anytime I see these patients, I'm pretty early on thinking about either transplant or palliative care because we know that people with systemic sclerosis don't do well who have ILD. It's a terrible disease. It tends to be very progressive, very debilitating. I will say that from a transplant perspective, they're a pretty tough population to transplant. And I say that only because they do tend to have these very patulous esophagi and they have a lot of dysmotility, or sometimes their esophagus is amodal. And that just doesn't bode well. You can't put a new set of lungs in somebody who's going to automatically reflux, and then their entire immune system is going to rush to their lungs and they're going to reject them. So, transplants in these populations are fewer and further between than in other populations. Again, I still refer, I still have the transplant team evaluate them because of that. Some of them do have, their esophagus does work and they are able to get a transplant. But I just always do put a little bit more of a disclaimer when I refer these folks so that people aren't, don't have false expectations, I guess I would say. Obviously, vaccines, we talked about that last time, and then introducing the role of palliative care, because again, it tends to go, the systemic sclerosis, ILD tends to progress quickly. People tend to do poorly. It's a tough deal.
So, in summary, and some of the things that the point of this entire program wants to get across to you is number one, recognizing that high risk ILD and diffuse systemic sclerosis. These are patients that need to be treated aggressively and referred aggressively from rheumatology to pulmonology, and then again, as Erica mentioned, on to transplant if needed. The importance of early recognition of the progressing and fibrosing ILD, initiating immunomodulator therapy, again, mycophenolate or myfortic, as she mentioned, and the timing of that antifibrotic therapy. And again, Erica knows way more about that than I do. I know that with the GI complaints that a lot of these folks have, the newer drugs with the less diarrhea and those types of things have got to be welcome
Mm-hmm.
alternative. Um, and then again, that timing of the referral for transplant. Um, but proper expectations, as you mentioned, Eric, I think that is also very important. I have had a patient who was turned down for that very reason, that, hey, if you aspirate, then this is all for naught. So we're sorry, we can't, you know.
Yeah. And there are places that will transplant them and say, hey, we will transplant you if you will live with a GJ tube for the rest of their life. And Cleveland Clinic does that. I will say that Vanderbilt is not as likely to do that. But there are places that will say, hey, if you're willing to live with a GJ tube, and this isn't like something that's going to be reversed, that's how you should expect to live for the rest of your life, then they'll do it. But again, that's a pretty big trade-off. And I've only had one person who's really taken them up on that. The other thing I would say is I am very quick to call rheumatology if I see any worsening of their disease. Their disease tends to present a lot more commonly with an NSIP pattern ILD. Again, still progressive fibrotic ILD, but it's NSIP pattern. So if I see a decline in their PFTs and there's a lot of ground glass, I'm going to very quickly call Robert and say, hey, I think we need to escalate immunosuppression, because again, like doing this early, going at them pretty hard tends to be better because they have such poor outcomes.
And of course, these are the ones that you do have to watch closely with respect to steroids as well, because initiating high dose steroids is probably kind of a no because it could put them into a renal crisis as well. So you have to be careful. You have to use them sometimes, but you don't want to get into the ultra high doses like we do with a lot of other things that we treat in rheumatology. So,
Mm-hmm.
all right, let's go on to the next slide there. Thank you. So, final thoughts. Number one, what are some key takeaways across both of these cases? And I think it's early recognition and early testing and early intervention. I mean, it really boils down to that. Understanding that a good history and physical is key with these people, knowing that if they have any sort of lung symptoms, you have to do the testing, listen closely, do the chest x-ray, take that where it follows, with the high resolution CT and the pulmonary function testing and so forth. Um, so Erica, how do you think that all of this has shaped your framework and how you deal and share patients with rheumatology who suffer from folks like these cases tonight?
Yeah, I think my biggest takeaway is how quickly I am to pick up a phone and call rheumatology, because the only way that these patients do well is if there's this coordinated effort between rheumatology and pulmonology, so that in case things start going downhill, we can immunosuppress them further. Or if rheumatology sees them and says, hey, they're underlying disease, their RA is really well controlled, but they're having progressive disease, they can punt over to me and I can say, hey, let's start some antifibrotic therapy. So I think that that's probably the biggest key that I take away from these patients.